Good morning. My name is Dr. Douglas Lee, and I'm a pediatric pulmonologist. I'm also the Associate Director of the Cystic Fibrosis Program at the UCLA Mattel Children's Hospital. And today, I'm going to talk to you about how to care for your lungs at home with medications for those with cystic fibrosis. Remember, if you have questions or comments, please place them on either Twitter or Facebook. Our goals today are to first talk about what's exactly happening inside your lungs, focusing on specifically the mucus. Then we'll talk about treatment options, who is eligible for these treatments, and what exactly these treatments can do for you. So what exactly is cystic fibrosis and what causes it? So CF is caused by an ion channel defect. This ion channel is located in the lungs and also throughout the body. Its function, at least its main function, is to move chloride into the airways in the lung. This here is an airway cell. And you can see on this orange line on top is where the CF ion channel is located. Its main function is to move chloride into the airway here so that these small hairs called cilia can function. These cilia beat and they require a liquid layer created by the CF ion channel to function appropriately. And they beat so that they can move mucus up into the airway and out so you can cough it out. And the function of these cilia is crucial to the overall health of the airways. And I have a video here which will first depict what happens in a normal airway. And we're going to take a closer look so you can see the system functioning in a healthy patient. You have the beating cilia in the liquid layer, flowing mucus on top. And this mucus is flowing up so you can cough it out. And we're going to take a closer look at what happens inside the CF ion channel. So looking in, so here, we're going to zoom in. I'm going to see the CF ion channel on the airway surface. Here are small chloride ions, and they're being put out into the airway and floating away in this liquid layer created by this ion channel. For those with CF, you'll see that this ceases to function, and these chloride ions are actually stuck inside the airway cell. What you have eventually is loss of this liquid layer. And this liquid layer is necessary for the cilia, and as the liquid layer disappears, cilia cease to function, and the mucus starts to sit on top of the cilia. Now the problem with that is that you'll have bacteria start to sit and invade the mucus. And it starts what I think of as the vicious cycle. This vicious cycle starts with infection. And this infection is with bacteria that are there because the mucus is not appropriately cleared out because it's thick and dry. And as the body starts to battle the bacteria, there's release of various inflammatory measures. And these start to slowly damage the airway, leading to what's called bronchiectasis. And bronchiectasis is destruction of the small airways. Once this damage sets in, you have a predisposition to have both the infection and the inflammation. Thus, the vicious cycle is characterized by initial infection, inflammation, and ending with lung damage. So what does this cause eventually? It causes eventually loss of lung function. So I have this graph here, which is lung function by age. This is from the Cystic Fibrosis Registry. So there's a registry that basically has all the data from all the patients in the US that's compiled yearly and put out in a special report so we can see what's happening. And you can see, and this is the data report from 2015, you can see that generally, as patients get older, there is a general loss of lung function. Another way to think about it is that you lose about 1 to 3% of your lung function per year on a normal basis. So now that we've characterized that CF is caused by an ion channel defect, which causes the mucus to be thick and unable to be coughed out, starting a vicious cycle of infection, inflammation, and damage with loss of lung function, what can we do about it? So I've depicted here the CF Foundation drug pipeline. So this concept was developed to show you basically that there are multiple drugs that were, through research and clinical trials, brought to your doorstep. And there's multiple classes of medications. And you'll see here as I start this video that there are various drugs in each class that are moving through the various stages of FDA development to reach your doorstep. The 4 classes I'm going to focus on today are mucociliary clearance medications, anti-infectives, anti-inflammatories, and our newest drugs, the CF modulators. So our first medication class is the mucociliary clearance class. I've taken basically the drug pipeline, which was vertical, and turned it on its side for this depiction. So you can see that there are a few that have made it all the way to your doorstep, and also a few that are hopefully on the way. And this is a general concept that I'll be reiterating, that there are multiple drugs that are available and many more hopefully on the way. The first medication within this class I'm talking about is hypertonic saline. So this medication actually has a quite interesting backstory. It was first noticed that surfers with CF in Australia had improved lung function to those who didn't surf. And it was eventually found that this was due to the inhalation of the salt water from this ocean, hydrating the airways and bringing water into the airways. So what we've done is added even more salt to that. So salt water has about 3% saline in it. We've added more salt to make it hypertonic, so about a 7% saline solution. It's inhaled twice a day. And what it does is, I have another depiction here. You have basically the airway cell on the bottom, the cilia or hairs in the liquid layer on top of that, and the mucus layer on top of that. So it does help to hydrate the liquid layer in which these hairs beat so they can function appropriately and given their critical part in our system. So this hypertonic saline is indicated for patients 6 and older and does have the benefit of improved lung function for you, improved quality of life, and reduced pulmonary exacerbations. Pulmonary exacerbations are acute infections for patients with CF, where the bacteria will start to spread and attack the airways. And you'll notice as I move on, these are very typical endpoints that we like to look at as physicians. Quality of life, exacerbations, as well as lung function. So the next medication I'm going to talk about is called Dorinase alpha. So another reason why the mucus with CF is so sticky, beyond being dry, is that in the battle between the white blood cells and the bacteria, the white blood cells die and release huge nets of DNA. This DNA is very sticky, and it causes the mucus to be very thick and very hard to cough out. So this medication called Dorinase alpha is an enzyme that cuts or cleaves the DNA at certain points. You can see here on this diagram, you have various DNA strands, and these small blue molecules are depictions of the Dorinase alpha, and you'll see them cutting it at certain points. It's an inhaled medicine, inhaled 1 to 2 times a day, and it is indicated for those 6 and older, and does have the benefit of similarly improved lung function, improved quality of life, and reduced pulmonary exacerbations. Our next drug class is anti-infectives. So one concept that I'd like you to understand about cystic fibrosis is that there is always an amount of infection in your airways. So we call this chronic or long-term infection, that there will always be an element of bacteria that sit in your airways, secondary to just the mucus being stuck there. So to try to break the vicious cycle of infection, inflammation, and damage, let's go after the infection. So once again, this is a drug pipeline with various drugs that have been approved for you, and also some that are hopefully on the way. Our first medication in this class is tobramycin. So tobramycin is an antibiotic with specific drug activity against a bacteria called Pseudomonas aeruginosa. So this bacteria is one of the most common bacteria in cystic fibrosis, especially for older children and adults. And in its IV form, tobramycin has good activity against Pseudomonas. What we've done is taken it and turned it into an inhaled solution so that you inhale it and it attacks the bacteria exactly where they're sitting, right inside your airways, right inside the mucus. It's used generally for bacterial suppression, meaning our goal is to treat this chronic infection. We know that there's always going to be bacteria there. We know as many antibiotics as we give you will never fully clear the infection, but we just try to keep the bacteria at a very manageable level in your airways. So this is inhaled a few times a day. There's 2 ways that you can take this medication. You have via nebulizer or also via a dry powder inhaler, currently available. It is indicated for those 6 and older with Pseudomonas aeruginosa in respiratory cultures, meaning that this bacteria should be found in your airways. And it does have the benefit of improved lung function and reduced pulmonary exacerbations. The next medication we're going to talk about is inhaled aztreonam. So this antibiotic is more broad spectrum, meaning that it attacks many different types of bacteria, but similar to tobramycin, it does have specific activity against Pseudomonas aeruginosa. And this antibiotic similarly is used for bacterial suppression, and it's a little different from inhaled tobramycin in that it is given 3 times a day versus twice. So if you think the third time might be a little difficult, the good thing to know about this medication is that even each nebulization only takes a few minutes versus 15 minutes or so. So shorter nebulizations, but has to be taken 3 times a day to be effective. And it is indicated, similarly, for those aged 6 and older with Pseudomonas aeruginosa in your airways. And it does have the benefit of improved lung function, improved time between exacerbations, so we're going to lengthen the time between exacerbations so there's overall fewer of them, and improved quality of life. The last medication in this drug class actually straddles 2 drug classes in my mind. So that's azithromycin. Azithromycin is an antibiotic typically used to treat respiratory infections, typically used in about a 5-day course. However, it does have the side benefit of being an anti-inflammatory. So we use it more for the anti-inflammatory effects, and it's given differently than the anti-infective dose of once daily for 5 days. It's given 3 times a week spread out, and it's given chronically on a long-term basis. And it does have, it is indicated for those with and without Pseudomonas who are 6 and older. It was initially studied for patients with Pseudomonas, but it does have some benefit for those without Pseudomonas. So that's in contrast to the other 2 medicines that I recently discussed. It does have the benefit of improved lung function and reduced pulmonary exacerbations. Our next class of medications is anti-inflammatories. So remembering our vicious cycle of infection, inflammation, and damage, now we're going to go right after the inflammation. So you can see that there is one drug that's approved specifically for that indication, and others possibly on the way. So ibuprofen is the one drug in this class that we're going to talk about today. So ibuprofen is similar to that you'd buy over the counter. It's a non-steroidal anti-inflammatory drug, and it's different than how you take it over the counter is it's given in very high doses, and it's titrated or measured to a certain level in the blood to be effective. So it does take a fair amount of blood work and effort to get to this level. It is indicated for those 6 to 17 years old, and does have the unique benefit of slowing the loss of lung function over time. So one thing that we like to think about is rate of decline. So that's, if you think back about what I talked about 1 to 3% of your lung function is lost per year. That is the general normal decline that you'll see with CF. So decreasing the rate of decline is nice because the slope will be a little more flat, and you can maintain lung function longer. So this is a fairly unique benefit that you get from this drug. And our last class of drugs is CF modulators. So modulators are the newest, probably the most exciting class of drugs, given that it's the first class that will work directly on the ion channel defect. Instead of working on the end effect or trying to clean up after what's happened, we're going right to the source and working on the actual ion channel to try to improve its function. So this pipeline is huge. There's a few that are approved, but also many that are in various stages of development. The first that we're going to talk about today is ivacaftor. So ivacaftor is a potentiator. So a potentiator works on ion channels that are at the surface already that aren't open, so the chloride channels, so the chloride cannot actually flow through it. So they're where they need to be, they're just not functioning appropriately. What this molecule does is attach and open basically the gate to try to allow more chloride through so the ion channel will function. And it is administered a few times a day as a pill. And here you can see in this video or depiction, you have the airway surface, you'll have the CF ion channel, and you'll see that not until this molecule attached did the ions seem to move through it. So that's one of our newest medications. Does have the added benefit of giving you improved lung function, improved weight gain, and reduce exacerbations. And of note, these effects are quite large. And backing up one step, it's very important to note that this medication specifically can only be given for certain mutations. And this is something that will be more and more common, and that we're trying to treat CF with whatever mutation you have specifically. So I've listed those here. Keep in mind that these indications can be changing, and there's many studies involving our current drugs, so this might change over time. So our next medication is a combination medication. So if ivacaftor was a potentiator, meaning it works on the ion channels at the surface, let's add on a second drug that'll help more ion channels get to the surface so that ivacaftor can work on it. So that's a combination medicine called lumacaftor with ivacaftor. So this is a corrector to bring the ion channel to the surface, plus the potentiator to work on it once it's there. And it's also given twice daily as a pill. And I'll show you in this video here that you have first the CF ion channel within the cell trying to make it to the surface, and once the molecule attaches, you'll have it attached to the surface where it can start to function with the help of ivacaftor. So this medication is currently approved for those 6 and older with 2 copies of delta F508, which is the most common mutation with cystic fibrosis, and does have the benefit of improved lung function and reduced pulmonary exacerbations. And whereas you might see that the effects are a little bit less than with the other drug, that this drug is very important in that it does treat many more patients, given that it does treat a more common mutation. The last class of drug that I'm going to talk about is not necessarily on the drug pipeline, but also very important in our treatments for you. So that's a bronchodilator known as albuterol. This is the same medication that we treat asthma with. And what it is a short-acting beta agonist. In other words, it'll go into your airways and relax the smooth muscle so that things open up, and it'll also help to prevent spasming that can happen sometimes with some of our treatments. So let's put this all together. I've given you a lot of different medications today. One important thing to note is that they must be taken in a certain order to be actually quite effective. The good thing is that order actually makes a lot of sense. So first, let's give you the bronchodilator. Let's give you albuterol. This is the medicine that helps to open things up and prevent any spasming. So we open it up first. Then we'll give you your mucus clearance medication, hypertonic saline ordonase alpha. We'll give you the medicine to help thin the mucus so that once you do your airways clearance, which I'll be talking about at a later time, these are therapies such as the VEST therapy, percussion therapy. These are therapies that will help to bring mucus out. And lastly, once the airways open, once the mucus is cleared out as much as we can, then we'll instill the inhaled antibiotics so that you give them time to sit in your airway and kill the bacteria exactly where they are. So remember, CF is caused by a defect in an ion channel that's located in the lungs and throughout the body. And its main purpose is to hydrate the airway so that the small cilia can function. Without it, you have mucus being thick and hard and sitting on top of the airway, which starts the bad cycle of infection, inflammation, and lung damage. Once the damage starts, you'll have the cycle going over and over again to eventually cause you to have loss of lung function. The good thing is that we have various ways to slow and alter this process, and this is constantly changing with time. So it's important for you to work with your physician to determine which medications are appropriate for you. So I've shown here our CF program here at UCLA. This is us at the 2015 North American Cystic Fibrosis Conference in Phoenix. So at this conference, which is held every year, our entire team attends to learn about all the new research, clinical trials, and treatment options for you. And To close, I've included our appointment line, our email if you have questions, and also a local chapter information as well as the CF Foundation. Thank you for joining, and I will take some questions. Okay, so I have a few questions here. I noticed that you spoke of drugs that are recommended for those over 6. What is available for those under 6? So that is a good question. Probably the best way to answer that would be to step back and talk about how recommendations are made to start with. Because yes, definitely a lot of the medications I listed today are mainly for those over 6. So recommendations from CF come from the CF Foundation typically, and a panel of experts that look at many different studies, what way, how good they are, and basically give us a recommendation, boil it all down to a recommendation and tell you how strong it is. And that relies on all the studies that were done. So definitely initially, most of the studies were done in patients over 6 because there's a lot more endpoints, as we call them, such as lung function. However, there's an emerging number of patients who are under 6 who are increasingly being studied. So what is recommended for those under 6? So there are general guidelines for those under 6. The general consensus is that the more symptomatic you are, the earlier you show, or the earlier you show symptoms, the more aggressively you'll be treated. So for instance, if you're an infant, typically we wouldn't give you some of the mucus thinning medicines unless you're having symptoms like chronic cough or difficulty breathing. But if you notice that, we're going to go ahead and start pulmozyme or, Dornase alpha or hypertonic saline. Otherwise, we just give you general recommendations such as get your child fully vaccinated, let's avoid infection the best we can, good hand washing, avoiding any smoke exposure. And those are generally how we'd say treat kids under 6, for the lungs at least. Okay. Are there any problems with interactions between the drugs? Generally, for the ones I listed, not so much. The majority of the ones I listed are inhaled, so they'll sit in the lungs, and they won't necessarily be what's called metabolized. The ones that are pills are metabolized. That's when you might run into some interactions. For instance, ivacaftor is metabolized or processed by the liver. So if you have other drugs that are processed by the liver, such as antifungals or some other medications, it might alter the levels of one or both. So that's why it's important to engage a physician and even a pharmacist, for more complicated regimens. But generally, the ones I listed can be all really taken together. You mentioned, next question, you mentioned 2 inhaled antibiotics. Do they work together if you take them at the same time? So that's a good question. It's not typically given like that. If you think about how we used things earlier, so initially all we had was inhaled tobramycin. The way it was used was to be given a month and then give you a month break and then taken again. And that was with the thought that possibly there could be some resistance forming, some bacteria that were basically resistant to being treated by that. If you give them the same antibiotic over and over and over again. That really hasn't played out to be the case. And actually it's thought more now that given that there's chronic infection, there's infection always there, that we should probably always treat the infection. So the routine now to use the 2 antibiotics, if you're on it, typically is to have you on one for 1 month, and then next month you switch over to the other one, and then the 3rd month you switch back to the first one. So they'll alternate month on, month off, but you'll always be on one if you're on them. So that's one option to be treated. But there are many studies, so who knows, maybe someday that recommendation will change. And our last question, when does lung damage start for my child with CF? So that's an interesting question. Lung damage is definitely the end result of some of the infection and inflammation. But if you look at children, even right after birth, infants who are born with CF, they have been shown to have some inflammation already in the airways, and also some changes within the lungs. I wouldn't say the same changes necessarily that are lung damage, the bronchiectasis or small airway destruction that I noted in the prior slide. It's more of air trapping and some mucus. But even after birth, you can see these small changes already happening. So that tells me probably there's some inflammation or some process happening in utero, even when the baby's still in the womb, that's starting to happen. At what point damage starts? If you're seeing some changes, it can happen probably shortly after that. But keep in mind with CF, there are many genes causing it, many gene modifiers causing and affecting how bad or how severe your CF is. So some patients might present very early, some might present very late. But we do know that, I can say definitely that after birth, that there is already some inflammation ongoing. So that's why it's very important if you're with a newborn screen or if you have a newborn screen positive to get in with a CF center as soon as possible so we can evaluate and start to treat you, because the lung disease can actually start right at birth. Okay, that's it for the questions. Thank you for joining me, and I hope to see you next time.